Chapter 23 in the Jarvis covers the neurologic system. While you're doing your physical exam, remember that you're trying to detect and document normal versus abnormal findings. Try to organize your assessment so that you collect your subjective data first and then obtain your objective data, analyze and interpret the pertinent findings to prioritize and create your plan of care. The focus of the neurologic system is to establish baseline and then document and track abnormal findings. And we inspect mental status, level of consciousness, the Glascow coma score, the cranial nerves, peripheral nerves, CSMTs, and then palpate, sensation, Babinski's, and stereognosis. Our subjective data questions include, have you been having any headaches? And if the answer is yes to any of these, you would explore them further. Have you had a head injury? Do you experience any dizziness or vertigo? Have you had any seizures or tremors? Do you have any weakness? Any change or lack of coordination? Are you experiencing any numbness or tingling? And are you having any difficulty speaking or swallowing? Our neuro exam includes mental status, cranial nerves, motor function, sensory function, and reflexes. And it's really impossible to test the neuro system without also testing the musculoskeletal system at the same time because they're so interconnected. So you're going to assess the neuro system as you go down your head to toe assessment. So you'll test your cranial nerves while you're assessing the head and neck. You'll test the superficial abdominal reflexes while assessing the abdomen. You'll test the peripheral nerves while assessing the extremities. You'll record all neurological data together as a functional unit. So even though the assessment is done kind of area by area, the recording is done by body system, which is why we teach it as a system rather than as a head-to-toe approach. So use the following sequence for a really complete neurological exam. First mental status, then cranial nerves, then motor system, sensory system, and then reflexes. So as you walk into the room, the first thing that you do is you look at your patient and you determine their kind of overall alertness. We talk about this as being the AVPU scale. Are they alert? Do they make eye contact? Do they only open their eyes to verbal? Do they only open their eyes to physical or pain? Or do they not open their eyes at all? And that, though we refer to that as AVPU, is actually the first step in the Glasgow coma scale. So if you're alert, you get 4 points. If you are verbally responsive, you get 3 points. If you are responsive to pain, you get 2 points. And if there's no response, you get 1. Next is verbal response. So how is your person talking to you? Are they oriented? So we ask them when we introduce ourselves, can you tell me your name and date of birth? Do you know where you are? What brought you in? Who's the president? Do you know what holiday is coming up? What year is it? So you're kind of asking questions about person, place, time, events. Are they oriented? Is their speech clear and appropriate? Is the content appropriate? So that's 5 points. If they're talking to you and they're alert, but they're confused, so when you ask them questions, they give you answers that don't completely make sense. So, they say, oh, it's May 3rd, 1972, and, JFK is the president or whatever. And you're saying, oh, okay, they're alert and they're oriented to self, but they're confused about maybe place or time. Sometimes patients will use inappropriate words. So they'll be alert and they'll be making eye contact, and you'll ask them a question and you'll say, do you know where you are? And they say yes. And you say, can you tell me? And they say purple. And you're like, okay, purple's not a place. So that would be an inappropriate word. So it doesn't give you an actual answer to the question that you asked. And then incomprehensible sounds would be if you ask that question, like, tell me where you are, and they kind of like make a moan or groan or a grumble or a mumble. So it's something that's not actually a word. And then if they don't vocalize at all, that's a 1. Now, keep in mind that there are patients that just normally don't vocalize because of their baseline, and that's fine, because this is a score where we're going to give them a score on a 3 to 15, and that might be their baseline, but then we just document that that's their baseline, and then we see whether they're improving or declining. So best motor response, 6 is obeys commands. So you say things like, open your eyes, close your eyes, stick out your tongue, smile for me, show me your teeth, shrug your shoulders, turn your head, stick out your tongue, say ah, all of those things. If they're following commands, then it's a 6. And if they follow some commands but not others, it's a 6, because the question says, what is their best motor response, or what is their best verbal response, or what's their best eye opening? So what's the best response that you ever got during your interaction? If they never follow commands, but if you do something and they purposefully push you away, then that's localization of pain. And if you were to draw a person, I'm just going to draw a person here for a second. Let's say that this is the chest, nipple line, and then I'm just going to draw kind of a 4 quadrants, but being like below the nipple line, above the nipple line, and down the middle of the sternum. In order for it to be considered actual localization, the person's hand needs to come up and either above this line on the same side or across kind of that center axis or that center X over to the other side, or even this way. But they have to break one of those planes. So the recommendation is that you, as the examiner, use pinching of the trapezius muscle here as the noxious stimuli rather than a sternum rub, because the sternum rub will just bring a hand upward towards the center of the chest, and we really want the hand to come all the way up in one direction or the other, like above that nipple line. So this helps us distinguish between localization of pain and withdrawal from pain. And what happens when somebody withdraws is they flex as a reflex to noxious stimuli. So when you're pinching or starting an IV or putting in a Foley or putting in an NG tube or whatever you're doing, the person has an increased tension in their muscles and they flex at the joints. They can't actually localize the pain, but it's more like they're trying to move towards a fetal position, or they're just flexing and the arms are coming up, but they're not actually trying to stop the noxious stimuli. So when obeying commands, they kind of know what's going on. Moves to localize pain means that they're trying to stop you from doing what you're doing. And flexion withdrawal means that they're trying to get away from you because it hurts, but they don't have the ability to localize the pain and try to stop you. Then we have posturing. So 3 and 2 are posturing, these two here. And decorticate is where you have flexion of the major joints. So the hands come up, cover the chest, and extension, the hands are at the side and extended, and that's decerebrate posturing. And then 1 point for best motor response is no response at all. So the reason that these are so important in terms of getting the appropriate score for each section is that there's really little subjectivity to these. Like the patient either does it or they don't. And then you can total up the scores at the bottom. And it tells you that the best response that somebody could have is a 15. The lowest response that they could have is a 3. So, my table is a 3, my computer is a 3, my shoe is a 3. But, everybody sitting in class is a 15. We consider this, though, to be kind of a critical value. So when you're thinking about a score, there's a couple numbers to keep in mind. As they trend downward and they start to get less than 12, we start to get concerned about their ability to, really answer questions appropriately. They're probably cognitively impaired at this point in time, and we have to watch them very closely. But as they approach this 8 number, if they're 8 or less, they probably have lost the ability to protect their airway. And so we have this saying less than 8 intubate, which is not true of every patient, but it is true of patients who started out at a 15. So if your baseline is a 15 and you're now an 8 or less, you're probably going to get intubated because you probably have enough central nervous system depression that you no longer can either protect your airway or adequately ventilate and oxygenate yourself. So that's how we use the Glascow coma scale. We use it either frequently or hourly or shift to shift, depending on how it's ordered and the setting that we're in. But the ambulance uses it when they first get to the patient, and then when they drop the patient off to show like trends on how the patient is changing. The ER uses it when they first get the patient, and then with subsequent vital signs, and if the patient's admitted or transferred, it gets done again to show how the patient is changing. And the ICU uses this as well with their neurological exams, and sometimes it's ordered on the floor. So the AVPU scale, as I said, is kind of that first part of the GCS. And if they're alert, check that orientation. So person, place, time, and events. Because sometimes people are alert and they seem to be really with it and they're completely confused and they're just confabulating and they tell this really great story until you start asking questions and you figure out that they absolutely have no idea what's going on, but they're super good at lying and covering it up because they've probably had long-term memory loss and they're just accustomed to lying and telling stories to hide it. You're going to look at their appearance and their behavior. So think about how well are they doing kind of taking care of themselves or meeting their basic needs. Are they well groomed? Are they dressed appropriately for the time of year or the circumstances? Are their actions normal? Is their behavior, appropriate and rational? Is their speech fluent or is it fragmented? The pace, the volume, the clarity, the spontaneity, and we'll talk more about this in mental health as well, but fast-paced, rapid, like pressured speech is a sign of mania versus like very slow, quiet, dull, flat speech would be a sign of like depression or a very flat affect. And then think about their cognitive function. So how is their memory, their attention span? Can they do calculations? So count back from 100 by 7, their thought process, abstract thinking, judgment, insight, emotions. All of those things are kind of critical concepts when you're thinking about the person's overall mental status. Sometimes we ask them questions like, what does it mean that you can't teach an old dog new tricks? And a person who has very concrete thinking will say, oh, that just means like an old dog is too old to learn something new. But a person who does not have concrete thinking, which is not normal, will be able to explain what that means in terms of kind of why we say that kind of saying. So, or people who live in glass houses shouldn't throw stones, or a penny or saved as a penny earned, or whatever. So there's all sorts of like little sayings that we have culturally that if you have concrete thinking, you can only think about them in the actual words that are used to explain them. The mini mental status examination is used usually just in primary care or in like neuropsych. We don't use that on the floors as much, and almost never in the ER, but this would be to test for Alzheimer's or dementia. Some neuro vocab that's important. So apraxia is the inability to perform purposeful movements or to make proper use of objects. So this would be like the Little Mermaid, where she was combing her hair with her fork. Agnosia is the inability to identify common objects. So you hand your patient something like a pen and they call it a banana. Ataxia is the inability to walk due to a balance issue, usually cerebellar dysfunction. There are a couple types of aphasia, and aphasia is the inability to express yourself or to speak. There's expressive aphasia, which is also referred to as Broca's, and that comes from the Broca's area in the brain. That's difficulty forming words. And then there's receptive aphasia, which is also referred to as Wernicke's, and that's difficulty understanding words. And then there's global aphasia, where you can't understand or form words. The Cincinnati Stroke Scale is used pretty routinely across the country as a quick way to test for ischemic strokes. So 80% of ischemic strokes will have one or more of these symptoms. So it's a quick way to test to rule in a stroke, but it can't rule out a stroke. So you're looking for things like facial asymmetry, pronator drift, and slurred speech. The cranial nerves should be tested. Again, olfactory is difficult to assess, usually in the acute or subacute setting, but the rest of them are fairly easy to assess. So cranial nerve 1 is the olfactory nerve. It's not routinely tested, but it tests the sense of smell. It should be tested in those who report a loss of smell, have head trauma, abnormal mental status, or when you think that there's a lesion. And remember that an abnormal sense of smell in a head injured patient could be a sign of a basilar skull fracture. So with their eyes closed, occlude one nostril and then give them something in a cup with a lid on it so they can't see it that they could smell. So things that they suggest would be coffee, orange, vanilla, soap, or peppermint, and then try it with the other side of the nose. So normally a person can identify an odor on each side of the nose, normally decrease with aging, and any asymmetry in sense of smell would be an important finding. Again, if this is an acute thing, you would want to notify the physician, because if they don't already have a head CAT scan ordered, they need one. Cranial nerve 2 is the optic nerve, which tests visual acuity and visual fields by confrontation. So using the ophthalmoscope, you can also examine the ocular fundus, and this is where you just test the visual acuity, like how many fingers am I holding up, or you can actually do a visual acuity exam. Cranial nerves 3, 4, and 6 are the ocular, motor, trochlear, and abducens, and these test the pupillary movement, extraocular movements, and pupillary kind of constriction and consensual light reaction and accommodation. So look at the palpable fissures, check pupils for size, regularity, equality, and then the direct and consensual light reaction and accommodation. Assess extraocular movements, and then nystagmus. So remember we talked about 3 kind of being at the top, 4 kind of being down, and 6 is kind of this lateral side-to-side movement. 5 is the trigeminal nerve. So when you talk about trigeminal neuralgia, it's kind of from the ear and spreads out almost like a hand slap across the face. It has both a motor and a sensory function. So the motor function is the mastication muscles. So the person should be able to open and close their jaw. So you're palpating the muscle as they clench their teeth. And then sensory function is with the person's eyes closed, they should be able to feel their forehead, cheeks, and chin if you just touch them lightly. That tests all 3 divisions of cranial nerve 5, which is the ophthalmic, the maxillary, and the mandibular. It's called the trigeminal nerve because there's 3 branches of it, tri meaning 3. Corneal reflex is only a test that you do if the person has abnormal facial sensation or abnormalities of facial movement. So if you have a problem with cranial nerve 5 or cranial nerve 7, you could do the corneal reflex. So with this, you can't have any corrective lenses. Have the person look straight forward, and I stand at the side instead of in front of them, but bring a wisp of cotton or a Q-tip or something in from the side so that they don't see it, and touch the cornea but not the conjunctiva from the side, and the person will blink bilaterally. So the corneal reflex is decreased or absent in people who have worn contact lenses because the cornea is used to being touched. But a normal response is blinking if there's anybody tries to touch your eye. Cranial nerve 7 is the facial nerve, and that also has a motor and a sensory root. The motor is symmetry with smiling, frowning, and closing the eyes tightly. So you should be able to resist somebody else opening your eyes for you, lifting your eyebrows and showing your teeth. So that's the smile. The other thing that you can do is have the person puff their cheeks out full of air with their lips pursed together. And then you can push on their cheeks to see that the air escapes equally from both sides. But the inability to hold air and puff cheeks would be a problem with cranial nerve 7. Sensory wise is only if you suspect facial injury. You can test the sense of taste by applying sugar, salt, or lemon juice to the tongue and asking the person to identify taste. So the kind of most distal portion of the tongue, the part that sticks out, is innervated by 7. 8 is the acoustic nerve. So sometimes it's called vestibular cochlear as well. Test hearing acuity by whispered or voice tests. So this was doing the whispered test or rubbing your fingers together, something so that the person can test soft sounds in their periphery without a visualization. Cranial nerves 9 and 10 are glossopharyngeal and vagus. For motor function, you're going to depress the tongue with the tongue blade, and then the person should say ah, or even if they yawn. The uvula and the soft palate rise. It should be symmetrical, and the uvula should be midline. And then the tonsillar pillars, which are on to the side, should move medially, so the whole oropharynx should kind of expand. Touch the posterior pharyngeal wall with the tongue blade, and the person should gag, and the voice should sound very smooth and not strained or muffled. For sensory function, for cranial nerve 9, there's no let's see, let me start over. Cranial nerve 9 controls taste on the posterior part of the tongue, but it's too difficult for us to test. That would be like a fine neurological exam. So it's nothing that we worry about. And we don't test taste for a bunch of reasons. So our major concern is airway. And so most of the time we're not sticking anything in the person's airway, including even just like sugar or salt or something like that, like lemon. So we're not going to test taste. Cranial nerve 11 is the spinal accessory nerve, and so you're going to look at the sternocleidomastoid the trapezius muscles, and then check for equal strength by having the person shrug their shoulders and rotate the head from side to side, so the chin towards the shoulders. They should feel equal and strong. If there's absolutely no suspicion of trauma, you could provide a little bit of resistance to the chin as they're rotating from side to side to test for strength, but you don't have to. You can also just observe a head turn. And then cranial nerve 12 is the hypoglossal nerve, and you want to look at the tongue. There shouldn't be any wasting or tremors. The forward thrust of the tongue should be midline, and they should be able to lift it, and it should still stay midline. Ask the person to say light, tight, dynamite, and you should be able to hear the consonants, like their speech, their articulation should be really clear. If there is a lesion, the tongue will deviate towards the lesion. All right, so now we're going to inspect and palpate the motor system, so like the muscles, thinking about the size, strength, tone, and involuntary movements. You want to compare the right side with the left side, and the muscle groups should be within normal size and limits for age, and should be symmetric bilaterally. And there is some crossover, obviously, between the neuro and the motor exam. So as you're going down after you've done the cranial nerves, you want to kind of do the periphery in conjunction with your musculoskeletal assessment. To test cerebellar function, you can do a gait. So have the person walk 10 to 20 feet, turn and come back, and look at their balance. The gait should be smooth, rhythmic, effortless. The arms should be swinging freely, and the opposing arm should swing forward. So the right arm swings forward as the left foot steps forward. Ask the person to walk in a straight line, heel to toe, to see whether or not they can maintain that balance, or you can ask the person to walk on their toes and then their heels for a few steps. Again, a lot of this is going to look like your field sobriety testing that you see done, because this is exactly what we're testing. We're testing for cerebellar dysfunction or cognitive impairment. Romberg's test is where you have the person stand up, feet together, arms at the side, and have them close their eyes for about 20 seconds. And then you want to make sure that they don't fall over. Make sure that with all of these that you're supporting safety and you're there to catch them in case they start to fall. Ask the person to perform shallow knee bend or hop in place, one leg and then the other. And this will make sure that they have proprioception. So you're testing their position sense, their muscle strength, their cerebellar function. Think though about what their baseline probably is. So if somebody normally walks with a walker, I'm not going to have them bend, hop, or otherwise. Rapid alternating movements. So ask the person to pat their knees with both hands, lift up, turn the hands over, and then pat the knees with the back of the hands, and then do this faster. So basically they're kind of flipping their hands up and down, up and down, up and down. And as they get used to it, they should be able to go faster and faster and faster and faster. Alternatively, have them touch their pointer finger to their nose and then to your finger, or touch their thumb to each finger on the same hand. So they go their thumb against their pointer, middle, ring, pinky, and then back, so pinky, ring, middle, pointer. So the finger-to-finger test is the one where the person touches their finger, your own nose, you move your finger, and they try to touch back. The other thing is you can have them stretch out their arms and close their eyes and then try to touch their finger. So right hand touches their nose, left hand touches their nose, right hand touches their nose, left hand touches their nose with their eyes closed. And you can have them move faster and faster. So normally once they figure out where their nose is with their eyes closed, they can go much faster. And then the heel to shin test. So you can, as the person is either supine or sitting, have them take their right heel, put it on the left tibial plateau and run it down the shin to the ankle, and then repeat with the left heel on the right tibial plateau, run it down the shin to the ankle. Assessing sensory then in the periphery. So thinking about pain, you can give a sharp and dull sensation to make sure that they can differentiate between sharp and dull. You can do like a pin or just be really careful you don't use like a sharp needle because you don't want to actually make them bleed. But you could do a sharp ballpoint pen, or some people will break like the Q-tip stick and use that as the sharp. And then for dull, you could use the other end of your pen, or even the cotton tip. Light touch would be a cotton wisp, like a cotton ball that you've kind of pulled apart so that it's very wispy. And then vibration, again, a lot of places don't have tuning forks anymore, but if you did have a tuning fork, you could strike it and then take the vibrating fork and put it over the distal phalangeal joints to see whether or not the person could sense the vibration. With position, passive range of motion, great toe and index finger to see whether or not they can sense that you're moving them. And then discrimination. So these are tests that are done to see whether or not somebody can recognize objects or discrimination of distinct sensory. So stereognosis is you put an object in the person's hand and they feel it and they can decide what it is. So if you had your eyes closed and somebody put a key in your hand, you would recognize the key just based on the size, the weight, the shape, the texture, the form. You'd be able to say like, hey, that's a key. If somebody put a pen or a pencil in your hand, same thing, you'd be able to tell what it is. Somebody who's had a stroke oftentimes loses object recognition. So that is a good test to do. Graphesthesia is where you draw a large number on the palm. So you might draw the number 1 or 2 or 3 or 4 or 5, 6, 7, 8, 9, 0, whatever you want to draw. But you can draw a number on the person's palm and then they're supposed to tell you the number. You could also technically do that with a letter. And I've seen, kids used to play this game where they would do it on each other's back, like they would write words or numbers on each other's back. But it's the same thing. If your sensation, your light touch sensation is intact, you should be able to recognize that shape from how you feel it on your skin. And then there's point localization. So having the person seated and closing their eyes, you touch a point on their arm, and then with their other arm, they reach over and they touch the same point that you just touched, so they can localize the same area that you just touched. Just a note on reflex arcs. So there are certain reflexes that don't require full transmission of impulse all the way to the brain in order to generate a response. So if you notice, like if you touch something and it's super hot or sharp and it hurts, you yank your hand back before you even realize that you burned yourself or that you hurt yourself or that you whatever, because of the reflex arc. And that's a protective mechanism. So it's a much faster response than it takes for it to go all the way to the brain. When you're assessing deep tendon reflexes, there's a 4-point scale that you can use. 2 is average, just like with pulses. 0 is no response. 1 is diminished. 2 is normal, 3 is a little brisker than normal, and 4 is hyperactive or with clonus, like where it spasms or it gets stuck. So these are important to remember, especially as we're kind of moving into maternity next, because some of our medications have stopping points based on deep tendon reflexes. In order to be good at these, you have to do them frequently. So this is not something that a lot of nurses routinely do. in their practice unless they work someplace like maternity or if they're doing these assessments normally in their set. So you're going to, again, head to toe, side to side, look at biceps, triceps, brachioradialis, patellar, quadriceps, and Achilles reflexes. And you've probably had these done before when you were in an office. And these just give you, this is a picture, it includes plantar as well, but, which would be like a Babinski, but this just gives you an idea of some of the reflexes and where you would hit them with the reflex hammer. And you notice that sometimes you're striking directly onto the patient and sometimes you're striking yourself. So like on the biceps one, you're striking your thumb and not the patient, versus with the brachioradialis, you're striking with the flat end, the Achilles, the flat end, the triceps, the pointed end. And so how you use the hammer varies based on the location. So your biceps reflex test is C5 to C6. Support the person's forearm, have them really relaxed. One of the most important things when you're doing deep tendon reflexes is to relieve the tension in the extremity before you strike. So place your thumb on the biceps tendon and then strike a blow to your thumb. A normal response would be contraction of the bicep and flexion of the forearm. So you'll kind of get this little like contraction jerk. Triceps reflex, as you again have the person relax, so you're supporting the weight of their arm and you're kind of holding the arm out to the side like a scarecrow arm, and then you're going to strike the tricep tendon directly above the elbow, and the forearm should extend just a little, and then this check a little farther down. So this is C7, C8. So this is testing the spinal reflexes. Brachioradialis is again C5 to C6, and when the person is, so you hold their thumbs, suspend the forearm, help them relax, and then strike the forearm directly 2 to 3 centimeters above the radial styloid process. And then there should be some flexion and supination of the forearm, so it'll kind of jerk and turn just a little bit. When you are looking at a person's hand, wow, that is a great hand I just drew there. We talk about C6 numbness as being the 6 shooter. So if you were to kind of make a fake gun, this is C6. So this would be numb and tingling if there was impingement to C6. So we talk about this being your 6 shooter. Your quadriceps reflex, it tests L2 to L4, and this is your knee jerk. So they need to be sitting comfortably, let the legs dangle freely. Again, let everything relax. You're going to palpate the patellar tendon, so kind of that prepatellar tendon, and then strike just below the patella, and there should be a little bit of a jerk of the lower leg. And then the Achilles reflex tests L5 to S2, and the person should have their knee flexed, very relaxed, hold the foot in dorsiflexion, and then strike the Achilles tendon directly, and then the foot should plantar flex kind of against your hand, so you should feel a little tap or push against. So you've heard the term clonus before in relation to like tonic-clonic seizures, where the person has like a really tense episode followed by rhythmic shaking. We see this with hyperactive reflexes when there's like overstimulation of the nerve during testing. So if you support the lower leg in one hand, with the other hand, move the foot up and down to kind of relax the muscle, stretch it a little bit, hold the stretch. You shouldn't feel any further movement. but if there's clonus present, you notice these rapid rhythmic contractions of the calf muscle and movement of the foot. So this is caused by hyperactive reflexes, and this is an abnormal finding. So rapid rhythmic contractions, very similar to the way that we use the word for our seizure patients, is clonus. Some other reflexes that you'll hear referenced, these are not necessarily ones that a nurse would check without an NP level. So these are cutaneous reflexes or skin reflexes, and these would be testing like localized muscle contraction. So with the abdominal reflexes, have the person just laying down, relaxed. You can put something underneath their knees to just help relax the abdominal muscles. And you can use your pen or the back of your fingers or even the end of the reflex hammer, and you stroke the skin. So you move from the corner towards the midline at both the upper and lower abdominal levels, and this will have contraction of the abdominal muscles and then a deviation of the umbilicus towards the side that you're stroking. So if I start in the right lower quadrant and I stroke towards the midline, I should get a contraction of the rectus abdominis and the obliques on the right side, and that should pull the umbilicus towards the right side because only the right side is contracting. So it's almost like a tickle response where like just that area kind of contracts in response to being stimulated. There's a cremasteric reflex, again, not routinely done. You stroke the inner thigh on the male with the reflex hammer or the tongue blade. This would be inappropriate to use your hand. And then the testicle would elevate on the other side. And then the Babinski reflex, and this is one that you should test on anyone who's had a stroke or any sort of cranial dysfunction. Position the patient supine, relaxed. If they have had a stroke and you would need to keep the head of the bed at 30 degrees or whatever, that's totally fine, but you just want them on their back and as relaxed as possible. The foot should be relaxed and slightly rotated externally. So the medial malleolus should kind of be pointing up. And then with the reflex hammer, so you're using the reflex hammer as kind of the sharp end, but you can also use like the tip of your pen without the ink out, or you could use even your finger if you needed to. Draw up. So you're going on the lateral side from the heel kind of up and then inward across the top of the foot. So if this is your foot, like big toe, little toes, you're starting down here and you're coming up and then this way across. And the normal response is plantar flexion of the toes and then inversion and flexion of the forefoot. So normally what happens is like everything kind of curves inward on you, but a positive Babinski, which would be an abnormal finding, they kind of fan out. So the big great toe goes backwards, it dorsiflexes, and then the little toes fan out. And a Babinski is indicative of like a lesion in the brain or a bleed, but it's a normal finding to have the dorsiflexion of the great toe and toe fanning in babies. And that goes away usually by 1 year of age, definitely by 2 years of age. And so with adults, it should not be present unless they have some sort of problem. So again, it's super important to establish a baseline, but then recheck neurologic function as you're caring for patients. So when you think about head trauma or neurologic deficit due to systemic disease, it's really important that you monitor patients closely for improvement or deterioration in neurologic status and any indication of increasing intracranial pressure. So let's talk about what increasing intracranial pressure actually looks like, because it can signal that there's some sort of impending event about to occur, like cerebral disaster and death, that if you recognize these early, you can intervene and prevent, which would be good on the good nursing scale. So use the abbreviation of neurological exams in the following sequence. So your AVPU, your GCS, your motor function, your pupillary response, and your vital signs. These are considered your motor neuro checks. So when somebody says do like neuro vital signs, this is kind of what we're talking about. We're talking about AVPU, GCS, pupils, and vital signs. So let's talk about increasing intracranial pressure for a minute. And as your intracranial pressure increases, your blood pressure has to increase as well in order to maintain a cerebral perfusion pressure that's higher than intracranial pressure in order to pump blood into your brain. So let me say that one more time. When your intracranial pressure increases, your blood pressure has to increase in order for your cerebral perfusion pressure to be greater than your intracranial pressure. So the cerebral perfusion pressure is the amount of pressure that the body has to pump in order to perfuse the brain. And that's higher than your ICP. So your ICP is kind of the overall pressure that's inside there, inside that cranial vault. So as the pressure inside your skull increases, your cerebral perfusion pressure also rises, which means that your blood pressure has to rise. So normally, if your ICP is normal, your cerebral perfusion pressure is like, 65. So with a MAP of 65, you will have normal brain perfusion. And as your ICP rises, your cerebral perfusion pressure, your CPP, also rises, and so your BP has to rise. So that's really critical. And the reason that that's really critical is because a rise in systolic blood pressure is one of the first signs that something's going bad. The person is going to have a change in respiratory pattern. They might chain stoke breathe for a while, but eventually they're going to have an overall minute volume that's decreased. So they're going to have a decrease overall in respiration, which means that their CO2 is going to increase and eventually their O2 is going to decrease. But the thing that's strange with all of this is that their pulse decreases, so they do not get tachycardic. So even though their blood pressure is rising, their heart rate is dropping. And this has to do with an increased pressure on the vagus nerve. And this is referred to as Cushing's triad. So systolic hypertension with bradycardia and bradypnea, or a strange slower, irregular respiratory rate. At the same time, as the intracranial pressure is rising, if the person has herniation of the brain stem, you'll start to notice either unequal or bilateral fixed and dilated pupils, which we refer to as blown pupils. And this is called doll's eye. So doll's eye, I want to talk about what doll's eye actually is. Doll's eye is when somebody has a blank stare and you turn their head from side to side, the eyes stay pointed towards the ceiling. So the head turns from side to side and the eyes stay pointed at the ceiling. As intracranial pressure increases, then you have the absence of that reflex. So it's called the oculocephalic reflex, but you lose that reflex. So now you have a fixed gaze, but it's like, way off into the distance. And as you turn the head, the eyes stay in exactly the same plane as they were in. So you have the absence of doll's eye. All right, so if you notice any change or any evidence of increased intracranial pressure, you are going to Call the physician right away. So posturing, altered mental status, pupillary changes, Cushing's triad, keep the head of the bed elevated, oxygen, safety, seizure pads, call the doc right away. And then just to review posturing as well, it's really important that you understand the difference between flexure and extensor posturing. So decorticate or flexor posturing is flexion at the arm, wrist, and fingers with adduction of the arms so they're tight against the thorax, and then the lower extremities are extended, internally rotated feet with plantar flexion, and this tells us that there's something wrong with the cerebral cortex. So that's why it's called decorticate, because it's a problem with the cortex. With decerebrate or extensor posturing, the extremities are extended, adducted, internally rotated, pronated, and the lower extremities are still extended with plantar flexion. The teeth are clenched, hyperextended back, and then this has to do with lesion at the brain stem. So like the cerebral kind of malfunction at this point in time, and midbrain or the upper pons. So kind of the brain stem itself is damaged. If you see this, and you can see this mix, so one side could be flexor, one side could be extensor, the person could be seizing and then posturing in between. But just to give you kind of a general idea, decorticate has about a 6% survival rate to discharge, and decerebrate has about a 3% survival rate to discharge. So this is one of the reasons why we monitor really closely for this and track this, is because we want to intervene long before we get to this point, because we know once they get to this point, they have a really poor survival rate, because there's so much pressure inside their brain that there's really almost no way that they're adequately perfusing their tissue, and they're going to start to have cellular death inside their brain.